Buenas tardes, bienvenidos a otro webinar de Hearts. En esta ocasión, un caso económico para una buena inversión. Tenemos interpretación en los 3 idiomas. Por favor, localizar el icono en forma de globo en la parte inferior de sus pantallas. Al presionar sobre el icono de interpretación, escoger el idioma en el cual desea escuchar. Los presentadores hablarán en diferentes idiomas, así que hay momentos en que posiblemente debe ajustar su botón de interpretación. En este momento nos dicen que inglés, intérpretes de inglés, interpreters in English, please kindly start interpretation. También invitamos a todos los participantes a colocar sus preguntas en el icono que dice preguntas y respuestas, Q&A. Por favor, utilizar ese icono para sus preguntas. Y en el chat, por favor, colocar su nombre y de dónde nos acompaña. Nos encanta saber cuál es su lugar de procedencia y dónde laboran, y nos da una idea de quién participa en nuestros webinars. Así que, si ya están listos, por favor, colocarse sus cinturones. Vamos a tener una gran sesión, como siempre. Y los dejo entonces con nuestro moderador, el doctor Pedro Ordúñez. Adelante, Pedro.
Gracias, Gloria. Y buenas tardes, buenos días, buenas noches a toda la audiencia que está participando en este webinar de la serie de webinars de Hearts en las Américas, hoy para hablar de un caso económico para una buena inversión. Y también para celebrar anticipadamente el Día Mundial de la Enfermedad Cerebrovascular o del stroke, como también se le conoce. Así que les estoy saludando a nombre de la OPS y a nombre del equipo que está trabajando en Hearts en las Américas para que tengamos otro excelente webinar. Bueno, déjenme empezar a introducir este tema en lo que ustedes van avisando a sus colegas que este webinar ya comenzó. Yo siempre les digo, bueno, pasen la voz a los que no están todavía en la sala. El tema que nos atrae hoy es el tema económico. En una primera parte vamos a tener un primer segmento dedicado a hacer el caso económico de Harry y algunas de estas soluciones.
Hola, Lucas, estoy con problema en el micrófono, por favor,
vamos a tener qué ha pasado en uno de los países icónicos en el tema del control de la hipertensión.
So what has happened when it comes to hypertension? When it comes
se
to
llama que estamos en Canadá.
this is called.
Entonces estoy teniendo problemas con el retorno. ¿Algún micrófono está abierto, por favor?
I believe somebody's microphone is on.
Yeah.
Let's see.
Well, entonces.
Let's see. I'd like to tell you that in this second segment, we're gonna have the Canada case and 2 other countries. And of course, this is going to be a very, diverse webinar. We're going to have closing words from the president of the World Organization, Jenna Martin. So this is going to be a very interesting and complete webinar. And this is something that I asked Liliana to speak to us. She is with the Urban American. And now, of course, we're going to see how we're going to deal with the Republican and how we see how each country can actually do their releases. We did this for the Pan American magazine. Liliana, tell us how this is going to happen. Huh? Let's see how this is going to be. Thank you, Liliana. Well, it's really a pleasure. Can you guys hear me? Can you guys hear me? I mean, I'd like somebody to help me with the presentation. Huh? Of course, I'd like somebody from the technical team to help me out. Thank you, everyone. It's really a pleasure to be here with you in this webinar. So my name is Liliana Lipkin. I am for the Pan American Journal of Public Health, an editorial technician. And I'd like to do a brief presentation on this magazine that we are celebrating 100 years. So this was, good month of 120 years ago. And this is our exclusive page of Heart. And I will share with you the last 3 articles that we have done, and you will be able to see this in the 3 languages. Let's see the next slide. So this is our page that is dedicated to celebrating more than 100 years in our Pan American Journal of Public Health. You will find a lot of information from the magazine. And here, next slide. Here, this is where we are looking at our numbers from Heart. So basically, we have 3 articles that we have published in this month of October. In this part of the magazine right here, this is on the left, you can see recent published articles right there, right? So, well, now, in this first article, we have a brief communication talking about our initiative of Heart in Cuba and how this was implemented. So the 5 years of the implementation, and this was published in Spanish, but we do have the abstracts in English and in Portuguese, and we can share this with you if you are interested. Well, now this is a report from Heart in the Americas, innovations to improve the management of hypertension and the risk for cardiovascular disease and primary attention, right? Primary care. So this was the translation that was done. This is available, and we have the original document as well. Let's go to the next one. Huh? So now, after that, we have an editorial. This is called Heart in the Americas. This was a translation from English to Spanish. So we have the version, right, in Spanish as well. We can share this as well, the original. Well, now in this part here, we're going to speak about these manuscripts, and they are available in English and in Spanish and Portuguese. They are free, and you can basically read them in the language that you prefer. Again, there's no charge there, and this is really even available for everyone. So basically now, these manuscripts, we have 19 in English, 8 in Spanish. We have translated 7 from English into Spanish, and we have translated into Portuguese too. So we have right now in production, we have 4 articles, and they are coming, right? They're coming in Spanish with translation into English. So let's next slide, please. So now this is a presentation to let you guys know. I mean, you can see the link, right? You can see the link up here of our website link where you can reach this. But this is looking into our monthly visit to RPSP September 2022. As you can see here, we had more than 65,000 users and new users 63,000. So this is a little bit of what I wanted to share with you. And basically, this is what I wanted to, we're going to have a tutorial video done, so you guys can have access, right, to these numbers from us. So thank you. Thank you for this. Huh? So since it's been more than 100 years since this mission from Heart started, the Pan American magazine released a special on Hearts in the Americas. There are more than 25 original articles that include studies done in various countries in the region. It's available on our website. This initiative, Hearts in the Americas and the Pan American Organization of Health, really looks into improving the control of hypertension. Well, we know the cardiovascular disease is the main cause for death in the Americas, and this is how you can access our material. So basically, first you go in, you select Hearts in the Americas, then you select the language, right? So, and there you go. There you have the Hearts in the Americas and our Pan American magazine. So here's our link. Thank you. Well, fantastic. This is great news. This is great news that we have heard, right? How to have access to this. I believe this is something really good. What we can do, I mean, let's keep on going, right? We have more discussions to have here. Well, I want to take the opportunity to really greet everyone here who is participating, Hearts America, those from Colombia, Mexico, those from Dominican Republic, Argentina, Panama. I mean, I want to greet especially Teresa Ma from Ecuador. She's right here with her student listening in. I want to also take the opportunity to really speak with a country here that really surprised us in these previous days. This was in Uruguay, and Uruguay is the country number 26 to join Hearts in America. So I have here Dr. Campbell. We were talking about this, you know, and basically, I mean, this is something that we did. I mean, we saw how Uruguay came in, and we are awaiting this final confirmation. So, I mean, we are 26 countries now. I mean, this is really good, you know. Fortunately, we have, you know, the representation of countries that had not yet come, but they might join: Paraguay, Puerto Rico, and Uruguay. And well, I mean, as we grow, as we keep on promoting this, promoting our priorities, right? So I'll keep on mentioning these things, and basically, I mean, this is going to be a great opportunity, but obviously, I'm welcoming everyone, these new countries that might come to us. I mean, the country number 25, right? And Uruguay, number 26. This is great to have, you know, a country that joined Hearts again. Well, to get started with this first segment, this was an article that was done on public health. This is an economic case for the implementation of our programs. And Andrew, who is a director for the Global Hypertension, he will be speaking with us here, and I really appreciate his presence, and the only one who will be even here. I mean, we have CDC, we have those from Brazil. We have actually those from Brazil. There's CDC here. There's also Professor Andrew Morenca from Colombia will present this economic case. Let's go, Professor Andrew. Welcome to Hearts.
Thank you. Gracias. Buenas tardes, todos. Good afternoon, and thank you for inviting me to present today at the webinar related to the health economic case supporting Hearts in the Americas. And now I'm going to share my screen and make a brief presentation. So the title is Health Economic Case for Hearts Implementation. And as Pedro said, I'm Andrew Moran. I'm the Director of Global Hypertension Control at Resolve. I'm also a professor at Columbia University in New York. So in terms of at the global level, you may be familiar with this. It's called a hypertension cascade. It essentially shows in the first bar is the number of people worldwide who are living with hypertension. And then next to that, those who are aware of their condition, followed by to the right of that, the number who are treated and the number who are controlled. And every time that the bars drop, it represents a loss in quality, a loss in the potential to save lives. And as we see now that only 1 in 7 people worldwide with hypertension have their blood pressure controlled. Now you'll see at the global level from PAHO, from the World Health Organization, the goals are closer to 50% or more over the next coming decades. So we have a long way to go, but the Hearts in the Americas approach and Hearts globally is definitely on track toward improving the situation. At Resolve, we like to present the obstacles to improving the cascade that we just saw as a series of hurdles toward achieving hypertension control. There's hurdles in diagnosis, that's the first bar. Treatment, that's the third bar after those who are aware, and continuity of care. That's what comes after people achieve treatment and control. Retaining them in care is essential. But the reason that we often share this slide is not to go
Parece que estamos teniendo problemas con la conexión de Andrew Moran. ¿Sí? ¿La producción me ayuda a esclarecer este tema, por favor? ¿Sí? Andrew?
My apologies. I think I lost connection. I'm just going to pick up where I was. Can you now, hopefully you can now see my screen again.
Okay, thank you. Go ahead.
Okay, my apologies. My connection was lost. But the point of this slide is for all the factors that are part of the hurdles between us and improving hypertension control, only one of them, patient adherence to medicines, really relates to patient behavior. And even that can be improved by improvements in the healthcare system. Every other factor on this slide is really a matter of improving how we deliver hypertension care. And that's really what the Hearts approach is about. So these are the 5 components that we promote. They really align with the Hearts technical package. Using a simple treatment protocol with specific doses of specific medicines in a linear stepwise protocol. Second, ensuring a reliable supply of affordable, good quality medicines. Third, team-based care involving non-physician healthcare providers. Fourth, patient-centered services, often meaning delivering care near the patient's home or sometimes in their home. And then fifth is a robust health information system for tracking individual patients and also seeing how the program is performing. So what has Hearts globally accomplished over the last 5 years? Now I know Hearts in the Americas goes back longer than 5 years ago, but Resolve, we've been supporting Hearts for the past 5 years. Over the past 5 years, we've documented more than 350,000 health workers trained to deliver the standard Hearts package. We've documented treatment of more than 7.3 million patients in 21 countries. This is before the expansion of countries that Pedro mentioned earlier. And we've also documented that more than 2.8 million of these people have their blood pressure documented as controlled. And this is just within the prior 3 months of this estimate. So it could be even better than this. And one thing to mention is this crude control rate, if you just divide the bottom number by the middle number, you get a control rate that's approaching 40% control. It's certainly not close to our global goal, but it's a big improvement over the original 10 to 15% control rate that we talked about at the beginning. Now, Resolve is we have actually already launched in our second 5-year period. We're going to be working across 31 countries, including the additional PAHO countries. And we're targeting this global goal of greater than 50% hypertension control in the programs that we're supporting in partnership with PAHO, World Health Organization, and country governments. So our goal is to continue to implement and scale a standard WHO HARTS approach in primary healthcare settings. We want to improve access to preferred antihypertensive medicines. We advocate for decentralized care, delivering care in the community by non-physician health workers. And lastly, the design and implementation of lean, simple digital health information systems to derive systematic continuous quality improvement. And this is an example. I know there are many great examples from the Latin America and Caribbean region of simple protocols. I'm showing one as a good example from Bangladesh. You can see it has only 4 steps. It has only 3 pills, 3 medicines that the country needs to procure and move through their supply chain. So these treatment protocols improve outcomes. They're drug and dose specific with a schedule for titration. They standardize treatment of patients. They're easy to train health workers on these protocols, and it promotes task sharing to non-physician health workers. And lastly, as I hinted at before, these protocols facilitate drug procurement and forecasting. On the topic of access to affordable hypertensive medicines, I refer you to the Under Pressure report. This was prepared by Resolve to Save Lives and Doctors Without Borders, MSF. And we found in this report, we did a survey of medicine access around the world and medicine pricing. Most of the preferred and recommended medicines that you find in the guidance from WHO and PAHO are included on national essential medicines lists, and they mostly align with the World Health Organization 2019 essential medicine list. In terms of pricing, however, the prices of antihypertensive medicines vary substantially among countries, making them unaffordable to governments and patients in many countries. And there's really up to 40 times higher prices in some countries for some medicines. So clearly, there's an opportunity to lower prices, especially in particular countries. These are often either small countries or countries where the procurement system has been fragmented down to state or local levels, and there's not the opportunity to pool demand. So this is a big problem, and there's a lot of work to be done. Now, I won't get into the details here, but Resolve is supporting the improved access to antihypertensive medicines in a number of areas. I'll focus on Latin America and Caribbean. Really, this is a place where the PAHO Strategic Fund is a world leader. It has shown that pool procurement across the region can lower prices. And we saw that in the report, if you look at the section on PAHO and the Strategic Fund, that prices for single agent pills were really equivalent to what we consider the World Health Organization cost-based generic price. It's really the ideal price. So congratulations to our colleagues at the PAHO Strategic Fund who are offering a global model for other regions of the world. In terms of decentralized team-based care, we advocated because it's patient-centered, efficient, and it's cost-effective. And we've seen successful models of decentralization of care in India, Bangladesh, and Ethiopia. And we'd like to document other examples from the Latin America and Caribbean region. When we can decentralize, well, you'll see in coming slides when we talk about costing of HARTS programs, it's one way to lower the cost to the government. So why is costing HARTS programs important? Well, there are several things that are needed for a country to look at the HARTS program, whether it's in the Americas or other parts of the world, and commit to funding and owning that program. What are the things that are needed? We think that it's really important to have good primary care infrastructure. It's also important and necessary to have strong political will, commitment from the government, which can often be difficult to sustain when governments change. But this is an essential ingredient. And lastly, there needs to be financing. There needs to be a budgetary commitment to supporting the purchase of medicines, training of health workers, and paying of health workers' salaries, including for non-physicians. So these are all essential. And you can see that in this graphic about sustainability and scale up, there has to be that catalytic event that's shown in blue, the political commitment from the country. And so I refer you to this issue of the Pan American Journal of Public Health that was recently published. That was a special issue describing hearts in the Americas. Within that issue, there is this article called Building the Health Economic Case for Scaling Up WHO Hearts Hypertension Control Package in Low and Middle Income Countries. This table is table 2 from the paper, and it really distills a lot of what's found across the many programs and projects related to the health economic evaluation and costing of the hearts programs. So in terms of barriers, we think that in terms of governments sustaining and adopting hearts programs, there has to be a health economic analysis that can quantify the value for money, the return on investment, if you will. We also think that cost of medications is such a big barrier, as I highlighted. So quantifying cost effectiveness and budget impact gives countries specific benchmark prices, including medicine prices, that may encourage regional or global pooled procurement of medicines and blood pressure monitoring devices. Going down lower in the table, you can see many countries are considering the adoption of universal health coverage, health insurance coverage for their population. So in terms of the health, the control of hypertension, there has to be a comprehensive and inclusive health service evaluation, including costing and health economic evaluation of hearts hypertension control services in the context of integrating with other primary healthcare conditions and defining the benefits package that is part of the standard health insurance package for each citizen. And this, I know, is a big priority at WHO and PAHO, making sure that NCD care is part of a standard insurance package in every country.
Sí, por favor. Si puede hablar.
Lastly, there's a need for intensive engagement with local governments, medication and device manufacturers, health workers, patients, and families to engage them in this process of gathering information about costs, but also communicating the value of the HEARTS program, even despite the need for investment. So you're going to hear more from some experts who've been doing these costing exercises in Latin America. We also have some examples that CDC, Deliana Kostova, who's on this call, is assisting other country experts to perform costing of HEARTS programs. So you can see in the table on this slide some examples of some of the per patient per year costs that we have observed in some HEARTS programs. In Bangladesh, we see an estimate of $18 per patient per year. In Mexico, you'll hear more about this later, an estimate between $13 and $18 per patient per year, depending on which state in Mexico. And then lastly, we have recently, it's not yet published, but some results coming from Ethiopia, estimating the cost per patient per year at $8 per year. And in the right column, not only do these costing exercises give governments an estimate of what they need in their budget to afford this program, but it also gives us ways to optimize the program. For example, what happens if we do lower medicines to an ideal level, say at the PAHO strategic fund price? Or what if we shift tasks to non-physician health workers who have lower salary and more time to spend with patients? That can also lower costs. And there are various ways of efficiency for controlled hypertension patients, having them visit clinic less often, for example. So we use these costing exercises to inform decision-making and also optimize programs. And we have more costing exercises ongoing in Philippines and Thailand, and they're also planned for Nigeria and India. So in summary, the state of heart's hypertension control, Resolve-supported programs prove that national hypertension control programs are feasible in low and middle income countries and can save millions of lives currently lost to cardiovascular disease deaths. Protocol-driven treatment and decentralized team-based care are core components of successful hypertension control programs. Major obstacles to the scale of these programs are unaffordable medicines and weak health information systems for monitoring patients and improving quality. And lastly, I hope you agree now that hearts costing is essential for making the investment case for scaling up hearts to the national level in all the countries of the Latin America, Caribbean, PAHO region, and beyond for the world. So thank you for your time. It's been a pleasure to present to you today.
Muchas gracias, Dr. Andrew Moran.
Thank you very much, Dr. Moran, for your problem. We had any problems with translation, but it was good to practice English. So thank you. Please put the link on the translation of Dr. Moran's article. It's very important, and we are using as instrument to talk to the governments, because it's very important to control hypertension. You know that, but we know that we need to save. We do our job well. How much money can we save for this country, for economic development and the health system? I think that we can come back to this in some moment, where we can reduce the costs of the use of hearts, of this package of hearts. But we have a surprise, a work that we can share with you, with a country of 100 million inhabitants, and for what we have alliance with everybody. And we want to have a summary of this work with Ariana and Marco as soon as this presentation ends. And we want the material with the cost evaluation to be sold in Mexico. El programa de hipertensión y atención.
Mexico. In 2021, Mexico launched the HEARTS program to improve the prevention and control of cardiovascular disease risk factors in 20 primary care facilities in the states of Chiapas and Yucatan. This study projects the annual cost of program implementation and discusses budgetary implications for scaling up the program. District-level data on treatment protocols, medication costs, and other resources required to prevent and treat cardiovascular disease was obtained. The HEARTS costing tool was adjusted to estimate total and per patient cost. A partial implementation scenario calculated the cost of implementing HEARTS if existing pharmacological treatment protocols were left in place. The second scenario, full implementation, examined cost if program used HEARTS pharmacological protocol. Table 1 shows important data collected from the district and facility level survey instruments, including facility patient loads, patient risk factors status, and employed health provider within facility. Other surveys results included estimated of the average time health provider need to screen for total 10-year cardiovascular risk. Respectively, in the partial and full implementation scenarios, total annual cost to implement and operate HEARTS were slightly over $260,000 or $52.01 per patient per year, and $255,000 or $31.05 per patient per year in Chiapas, and $1 million or $41.03 per patient per year, and slightly more than $1 million or $43.03 per patient per year in Yucatan. In Chiapas, adopting HART's standardized treatment protocols resulted in a 9.7% reduction in annual medication expenditures relative to maintaining status quo treatment approaches. In Yucatan, adoption was nearly $30,000 more expensive, in part because HART's hypertension treatment regimens were more intensive than status quo regimens. HARTs in the Americas offer a standardized strategy for treating and controlling cardiovascular disease risk factors. Understanding the cost driver of the program is crucial for continued service delivery at the primary care level. In Mexico, most of the costs of the HARTS program were human resource costs to carry out evidence-based treatment protocols. These stem from national recommendations that patients present for primary healthcare visits between 3 and 12 times annually, depending on their cardiovascular disease risk level. Approaches that may lead to improved program affordability include the adoption of the recommended HART treatment protocols with preferred medications and task shifting of services from physicians to nurses and other providers.
Bien, muchísimas gracias. Le voy a invitar.
I will invite now Daliana, that is one of the authors of this article, and Dr. Andrew, that now to open their cameras. Congratulations for this job, wonderful you are doing, that is being published. Will you comment on the about this subject and how the countries can foster this program in order to carry out this program?
So thank you, Pedro. I can start and then hand over for Deliana for most of the answer to your question. But I just wanted to mention that what you raised before about making the case to countries also needs to include the money they can save from prevented heart attacks, strokes, heart failure cases. These are deaths. These are disabling conditions. They're costly to governments, they're costly to families. So that I didn't make that case in my presentation, but that's cost effectiveness analysis. It includes health gains and it includes cost savings. So we will definitely be publishing on that as well as the costing of the HARTS programs. So after making that point, I will turn over to Deliana, who can describe how this work is done, how countries can do costing of their programs. Over to you, Deliana.
Sure, Andrew. Thank you. Thank you very much. And I just want to say that this was a beautiful summary. And I am speaking on behalf of Dr. Carlos Chivardi, who is the lead author of the Mexico costing evaluation, which was done with the support of PAHO at the National Public Health Institute in Mexico. And so I'll try my best to answer the question specific to Mexico, because Carlos was not available for this this moment. And so, well, first I want to start just with an overview where Andrew's papers comes from, which is a synthesis of the goals and the approaches that are undertaken in the context of hypertension control by many partners who work in this area. So it's extremely important as a representation of the range of economic evaluation activities that are happening in globally in the area of hypertension control. And so where the Mexico work comes in as part of that evaluation is that it's a supporting example of some of that work. And specifically, as it pertains to the Mexico project, the example from Mexico highlights the importance of conducting hypertension program costing as a building block, almost an intermediary building block that takes us on the way toward the more final goal, which is specifically to demonstrate the returns on investment from this type of program and intervention. And this type of analysis answers the question of what is the investment? And in that, it's an important foundational analysis that would lead to answering that question of returns on investment and cost effectiveness. And also, the Mexico analysis informs, it lets us know why it's important, why so many of the partner activities that are discussed in the paper by Andrew Moran are important, which are based on activities that can inform important inputs of HEART's cost evaluation. And primary examples are the pricing of HEART's recommended medication and the effects of workforce task sharing. And so should I continue or we can go forward with the next question, Pedro? Because there is a lot more to be said on the cost effectiveness side.
Bueno, muchísimas gracias, Daliana. Muchísimas gracias.
Deliana, this is one part. We need to keep on in one of the areas where the countries can think about when they are starting HEARTs, when they are implementing HEARTs. But I believe that most of the countries don't have the resources. And fortunately, what you have presented, it's important because the balance, it's pending toward this smart investments in health. These are investments that are worthwhile. We are saving money from the countries. So I would like to give the last comment to Deliana. If you want to say some message about this subject or any other subject that you think important. Deliana, how the countries can use the tool of CDC in order to support their programs?
So yes, so first I want to say that it's very key to highlight the importance of assessing cost effectiveness of the programs. And one step towards getting there is assessing the costs that would be involved in scaling up the program at the national level or the larger level. And that can be done with the help of a Excel tool that is called the HEART costing tool that provides a platform for synthesizing the cost of the different elements of the HEART's program. And in terms of getting to the next level, which is evaluating the cost effectiveness, which is really the perhaps the end goal for stakeholders who are making the decisions. We a couple of years ago, we had conducted a systematic review of the literature on the cost effectiveness of hypertension treatment, specifically in low and middle income countries. And we found that across the board, it's typically very cost effective across a wide range of programs, interventions, and context in countries. So the general answer is yes, it's cost effective, but that's sometimes not satisfactory to individual countries, right? Because they want to know what their own numbers are. And that's where this country-based assessment comes in. And a couple of points that we should just quickly mention when we discuss the cost effectiveness and looking into the more complex sides, which has many. What really determines cost effectiveness and our understanding of the cost effectiveness of a program is, well, first of all, what is the threshold that we're looking at when we trying to determine what is cost effective? And second of all, what is the baseline situation in the country as it pertains to the status quo costs that are incurred and the baseline outcomes, health outcomes that we would compare the intervention to. And it's actually quite important what the baseline situation is when we are assessing both cost and cost effectiveness. And this was particularly evident in the Mexico study, where we saw that the cost effects of medication treatment for hypertension, and the cost effects meaning whether the average expenditure on drugs either increases or decreases under the HEARTS program compared to the status quo baseline.
Este es un tema muy importante, Daliana. Sí, vamos a seguir mirando este tema, pero está claro que lo que demostró el programa de Argentina también y lo de México, digo, y en otros programas, es que aplicando la metodología HEART es mucho más efectivo y económico hacerlo que siguiendo el status quo. Y este es un tema que es un mensaje poderoso que le estamos pasando a la audiencia. Quiero agradecer a Andrew y a Daliana.
Andrew and
Daliana, una de las acciones que estamos
one of the actions that we are carrying out is that we can reduce the price of drugs if we use another approach. This is what Andrew was talking about when he mentioned what they are doing with the drugs. So I will pass on the floor to the next panelist of this session, Nora Giron. She's advisor of PAHO, with PAHO. But first, I will mention the summary of an article on the use of drugs as an action of Latin American countries have available. Advancing to improve the access to drugs for heart diseases. The goals of this paper are to describe the intervention carried out by the Strategic Fund of PAHO in order to make possible the access and availability of drugs against high blood pressure and control of hypertension to the countries in the Americas in support of the HEARTS initiative. The methodology of the study included the review of reports published, the evaluation of the acquisition and the review of databases of public procurement for 5 drugs against hypertension and by the Strategic Fund. We identify different prices in different places for the list of high blood pressure medicines in markets with assured competence. Figure 1 shows the prices in 7 countries of the drug. We saw that the prices on Bevicul of 5 grams and 10 milligrams obtained by the ways of the strategic funds are lower than in most of the countries that were studied, 20 to 99% of difference. In this figure, we see that we can obtain a reduction of prices up to 69% for the combination and a certain combination 5 milligrams, and 83% for the combination Pensatal 80 milligrams, but 5 milligrams in the country A, comparing to the price already established in the strategic plan for the formulations of these drugs. Figure 2 shows the difference for 3 hypertension drugs varied 88% to 95% compared to the price of the drugs available in the strategic fund. This represents to multiply by 4 the number of patients treated, keeping the same budget. In this sense, the strategic fund of PAHO represents one opportunity to improve the access of drugs in the different countries with significant difference. This way, the strategic fund keeps working to help the countries countries in the Americas to have access to these drugs against hypertension, promoting the attention to demand and the attention to the procurement by the countries of the region. We present actions developed in with the HEARTS initiative, highlighting the procurement of drugs recommended by WHO, and this was obtained with special prices of products, generic products of quality, and the use of these drugs can count on with devices automatically of measure the blood pressures. Through this tool, the member states can improve their attention in a significant way with treatment and diagnosis to more people.
Bueno, muchísimas gracias.
Thank
Invito
you
entonces ahora a
very
Nora
much.
Girón.
I invite now Nora Giron. Nora, there are a lot of opportunities that it looks to me that we are not using in a proper way. So I would like to comment a little bit on this point. We would like do you have the drugs that can be used in by the strategic fund are of better quality comparing the prices? I tell you something else. I was in Argentina and in the province of Buenos Aires, they are asking how a province that is not the complete Ministry of Health, how can a province be part of the project? Thank you, Pedro. Thank you for making possible to be in the team of Heart Strategy, because we can learn a lot. We were able to achieve several innovations, and one of the most important elements is that in the countries, they start inclusion of drugs recommended.
Medicines that are actually recommended by the health organization. So we have done this ourselves. So basically, we have managed tracking this out, understanding how this is, to make sure that these lower grade medicines are actually available so that they can be actually purchased by the public. In other situations, other studies that we're doing at a regional level, we have seen actually that we have observed a few countries that are still purchasing this for those medicines, so that they already exist in the market by other producers, and that a strategic look at this might actually look at this. So there are 35 countries that have adhered to this basically all the Americas, so they can purchase medicines, supplies with this strategic fund. So there is actually a fund, specific fund that can support this. Last year, we did a partnership with the health secretary in Buenos Aires to start using this strategic fund. So what countries need to do basically is to present the OPS in each of these countries so that this can be checked by the providers so that there is an offer for that. So these products will be then coming from the strategic fund. So these are the elements that make it easy for us to consolidate this demand in these countries. So there is fractioning, there is the idea that these factors cannot help us really negotiate in a group manner. But if we had a bigger demand, let's say, by others as well, together with us, we could actually reach a better result. This is excellent. This is an interesting topic, really. We're getting questions in the chat because for sure strategic fund, if they have more demand, they can get a better price, right? So can negotiate a better price. So obviously, it is important that the provider be a good provider, obviously, that can actually supply these medicines at a good price and good quality. Well, we see here on the chat, Nora, I'd like you to add your email, your contact information on the chat. We will be looking at this. This is a powerful tool, really. Nora, there's one more thing that I want to talk to you about. We're running out of time. We have had a few technical issues when it comes to translation, when it comes to connection issues. So we need to move forward right now. I mean, I really appreciate everyone that has shared their perspectives and the aggregated value that we find in this economic perspective, really, to really continue to move forward. So I really appreciate all panelists, Andrew, for your presentation. Honestly, keep in touch with us. I mean, we are getting questions about this, and it's going to be great to answer, right? So basically, this is really good, really good. So the next topics will be a Mexican thing, actually, Mexico topic as well. So in the previous webinar, I mean, we published an instrument that we are using in the region, right? To tell countries how much you can do when you can actually control vascular, so blood pressure, right? So basically, let me ask Ramon to share Mexico case right now. I would like to have the link on the chat again so we can look into this, article. So let's look at Mexico case. This is the perspective. How much can we save in Mexico? Well, thank you so, Pedro, for this opportunity. I mean, we have developed this article. This is really a special work from heart. And one of the important results that we have found here is that we have developed a predictive model to help us have the association, between the number of people who have hypertension and check their heart rate, blood pressure rates, so to see the relationship between those things and to look at how this affects. So basically, this is an instrument, a tool, right, called Estimate Tool. This is available here. You can see the link, so you can actually have access to this tool. And I'll show you briefly the Mexican case for this. Well, listen. Let me refresh this here. All right. A moment, please. Okay, then. Okay. So there's a page here, and this contextualizes a bit of how the tool is going, how it does. So there's a menu here, and basically we see the information about this tool. So I want to show you this as quick as I can, how the tool actually works. So this presents America as a region. And see on the left, there's a panel here, and you can basically use different parameters to work with this instrument, and we can estimate what we can do, those functions that we can bring together, how we can control, you know, the population that have, if any, issue with blood pressure. So you can check region, you can check country, you can check area. I mean, you can actually choose as you please, really, and you will be able to look at the population that you want to look at through the studies, understanding, right? And you can see basically the goal that you want to reach. And as you look at those measures, so you look at those metrics here, in this case specifically, what you see initially is the numbers for treatments in the American regions. And one thing that we want to look at here is to improve, right, the percentage, right? Ramon, I mean, listen, sorry. I mean, we know what we have, right? So let's choose the country so we can show, right, how this happens in reality. Huh? Okay, so let's choose Mexico. I mean, there's an icon here that symbolizes a menu, right, like a setting. And here you see a list, like a table, right? A table with information, with the treatment that you find in the region. Okay, so let's go to Mexico. Let's go to Mexico. All right. So let's go to Mexico. So if you want to look at Mexico, you click here on Mexico, and basically you see the information. This is all then on the tool. So here on this window, as you can see the table. Oh, sorry. Hey, Ramon, listen. What this means really is that if anyone comes here and looks at this, we see that Mexico, I mean, we have about 27%, 27.7% of control of hypertension. Is that right? That's correct. So this means that every 100 people, we control about 27.7 of those people. So this is important, right? I mean, we need to look at this number, right? And we need to look at what we can do to actually lower the gap, right? I mean, looking at hypertension control in population, I mean, looking at these three variables, knowledge, treatment, control, right? So 57.6%, what does that mean? 57.6% means the total of those people who have hypertension, they have the condition diagnosed, right? And this is out of 100%. We see that only 57% know about the condition. Okay, so we have a 43% of the people who do not know, right? They do not know. And what is this here, the next number? The next number means that the amount of people who have hypertension, who know the condition, they have the condition, they are under treatment. This is 86.6%. So this seems high, right? Wow, look at that. This is a high number, but not really, right? Because this is, I mean, the people who are actually have access to the treatment, right? So they know about it, they have knowledge about it, they are aware about it. So when we look at those people who receive treatment, we see about 50-something%, right? Yeah, actually, there is a 45% breach. There's a gap here, right? There is a gap. They receive the treatment. I mean, those who don't receive it, those who don't know. So what does this mean for the standard that we want to achieve? You know, I mean, imagine if we get to 70%, let's say, of diagnosis, right? And how would you see that when it comes to, I mean, if imagine if we got to 70% control. What about that? Well, I'm only changing these amounts here as a target, as the goal, right? So this is diagnostic, have been diagnosed, and the control. Well, there are questions here on the chat. So 86.6% of the population have it controlled? No, not really. Of those 27% have control, 86 are actually being treated. So this is only for those who are actually having treatment. So this is a question that is important. Do this, say this, ask this, right? So we're clearing this, right? So we're making this clear. So, but let's go back here and imagine again that we have 50% of people who have treatment, and let's try to see that, Well, under these conditions, what we would have is we would have a 42.4%. That would be a good improvement, right? So we could save about 50,000 deaths and 18,000, almost 19,000 when it comes to heart function, to heart failure. So this is, I mean, we want to look at two of the cases, actually, okay? So, I mean, we're looking at this, and we're looking at this article. We want to make sure that you guys have access to this. So you can play around with these numbers, so you can actually calculate these data, right? Ramon, thank you so much. We're gonna go back to you in a few moments, but before, I mean, this is a webinar, right? This is a very intense webinar. Let's move now to the second part. We're going to speak with North Campbell from the university. So here we're going to change segment. Huh?
Hi, I'm Dr. Mark Jaffe. I've spent 25 years treating patients for hypertension at Kaiser Permanente, where we improved blood pressure control rates from 44% to 90%. I want to share with you why it's so important to use an automated digital blood pressure monitor. To increase control of high blood pressure, we need to make sure hypertension care happens where most patients get treatment, and that's in the primary care setting. To take blood pressure with the manual device, you need to do many things at once. Use your fingers to control the deflation rate, use your eyes to read a small dial or a mercury column, and use your ears to listen for the sound of blood passing through the artery. Doing this right takes a lot of training, and even experienced staff make mistakes. Now, an automated digital monitor does all the difficult stuff for you. It inflates to the proper pressure and it deflates at the right speed. It displays the numbers on an easy-to-read screen, and it doesn't require any listening. As long as you get a monitor that's validated, you can be confident that it will be accurate. Since an automated device is simple to use, training is easier and faster. That means healthcare workers can pay more attention to things like positioning the patient. Specialists might use other ways to measure blood pressure, but for primary care, automated digital monitors are the way to go. Hypertension treatment programs have saved many lives already, and automated digital blood pressure monitors can help save millions more.
Excelente, excelente, excelente. Quiero contar.
Excellent. Yes. So I want to tell you something.
This last week,
I was in Argentina. They were following the program. They were watching the
Congress of Cardiology,
and this was a big event, and the connection dropped.
With
so
the team
this
of the
was
Ministry
a team
of Health.
that was actually doing this. They had a big challenge they were working with
in Argentina,
right?
And
so, we want to talk
amazing
about
how many deaths
we can prevent,
we can
right?
avoid
in
Argentina.
We will share
And
results from Argentina.
we
But, we
Now
are looking at
we
this. I mean, there's a video that I want to show you.
I
I
want to
mean,
bring
this is a video
thank you
to
the people of
remind you really
Argentina for all the help and
of
the
this and the
attention
care
that
and the
they
attention that we received from
showed to me,
you,
especially
the
the people in
team
the
from
province of Buenos Aires, and it's they are. We saw. And I hope that this we are having interchange. It's important to have interchange for the team, for the countries. We want to take advantage to this to congratulate with the team of Bolivia and Cali, Colombia, two places where a place where a heart started, and it's important to know where you people from, so you keep sharing the good practice. But now the best practice for hypertension control comes from a country of this region, and it's an honor to us. We are very proud that the number one in hypertension control is Canada. Canada is not too far away. We are very close to Canada. We have the professor Noel Campbell. Noel Campbell is professor of University of Calgary, will tell us how the hypertension control in Canada is happening, and I hope
to thank you for the honor.
Muchas gracias.
On World Stroke Day. This is especially exciting for me because it's in relationship to the Hearts in the Americas program, which is probably the world's premier program for the prevention of stroke. I've been asked to talk about hypertension control in Canada. Between the year 2000 and 2011, there was an extensive effort to control hypertension in Canada. This was associated with the largest increase and the highest reported control rate achieved for any national population. Now, in the right panel, you can see the lack of awareness of hypertension in Canada was 43% of those with hypertension. The control rate was only 13%, and about a fifth of those with hypertension were either aware of their diagnosis and not treated, or treated and not controlled. This changed very substantively. This is data from 2011-2012, where we can see the control rate has gone up to 68%. Only 16% are unaware of their diagnosis, and only a sliver of those who are aware are untreated. Now, unfortunately, after 2011, there was a focus away from hypertension control, and the control rates declined in women, and specifically older women, from 69% to 49%, with a decline in the overall control rate in Canada to 58%. We can see that in the right panel. These are the rates of awareness of the diagnosis of hypertension, and we can see them declining after 2011. The rate of treatment of hypertension, and the rate of control of hypertension in these older women. Now, I'm just going to briefly describe the program for you. The program had a steering committee, and under the steering committee were 3 task forces. One task force was to annually update evidence-based treatment recommendations. These would be scientific recommendations based on evolving science. The real engine of the program, in my view, is this implementation task force. It would take the scientific recommendations and translate them into tools and resources for primary care, and to disseminate them. And then we had this outcomes research task force, which would really examine what was working and what wasn't working well, and identify clinical care gaps that it could report to the Implementation Task Force and the Recommendations Task Force to develop tools and resources to fill those gaps. There was a leadership position created in academia to try to accelerate the uptake of the program. There was a coalition of health and scientific organizations called Blood Pressure Canada, which had up to 28 organizations, which really oversaw public policy development from the health and scientific sector and had oversight for the development and implementation of a national hypertension strategy. The steering committee had the Hypertension Specialty Organization, the coalition, the federal government, and our Heart and Stroke Foundation representing civil society. But notice the heavy weighting of primary care, Family Physicians of Canada, nurses, and pharmacists. We also had formal partnerships with specialty organizations to try to prevent them from competing with our recommendations, but also so they would facilitate its uptake. Now, some implementation aspects of the program, the resources were aimed largely at primary care. They were developed with and by primary care experts and leaders. They were field tested and annually revised based on the field testing. New themes were developed each year based on clinical care gaps identified by the surveillance. There were 5 key messages really focusing on what's important for screening, diagnosis, treatment, and control. But each year would add 1 or 2 new messages based on the theme for the year. Different implementation resources included a 1-page summary, short and longer clinical summaries aimed at primary care, a short scientific summary aimed at specialties, and a very detailed manuscript outlining changes in science and recommendations. We had 6 standardized slide sets for education in undergraduate and postgraduate to try to standardize the messages that were going out to clinical care. And we tracked the numbers of publications on or about the program or its recommendations. Most of these were implementation articles aimed at primary care. And once the program was mature, there was 30 to 40 of these publications, largely in Canada, on the program. Now here we're looking at the national rates of prescribing antihypertensive drugs in Canada. The program started just following the 1999 recommendations. We see this large increase in prescribing antihypertensive drugs. Of much greater relevance to this group, here's the rates of dying of stroke in Canada, heart failure, myocardial infarction. The blue line represents the start of the program. We can see in Canada the rates of stroke were declining before the program, but there was a 5-fold increase in the rate of decrease of dying of stroke in Canada after the program, as one would expect from the dramatic increase in antihypertensive drugs. Similar findings for heart failure, less marked for acute myocardial infarction. The rates of dying of these conditions were closely correlated with the increase in antihypertensive drug prescriptions. So 2000 to 2011, we noted quite marked improvements in awareness and treatment of hypertension in Canada. The changes mirrored our recommendations. There was increasing intensity of treatment over time, improvements in blood pressure control, and most importantly, improvements in outcomes, and specifically stroke. The focus of the program was on enhancing quality and performance of primary care management of hypertension. Unfortunately, we learned an important lesson in 2011 that sustained hypertension control requires sustained effort. In 2011, the Hypertension Organization merged with much less emphasis on implementation and outcomes research, and had increasingly complex management recommendations, which would be hard for primary care to keep up with and implement. The program lost its oversight of the federal government, primary care, and civil society. We also lost funding from the federal government and the pharmaceutical industry. Hence, we saw this fairly marked reduction in blood pressure control in women, specifically older women, by 2016-2017. We did not see similar declines in men. The reasons for that are still unclear. These are some suggested reading for you that you might get further information on our program from. Again, I thank you so much for the opportunity to speak with you.
Excelente, excelente
very comprehensive summary, very comprehensive of what happened in Canada, what is going on in Canada. I will come back with Campbell if there is any question, but before, I would like to invite Dr. Patricia Lawrence William, advisor of non-transmissible disease of PAHO. She worked in Barbados, in the Barbados office, and she was in charge of the Caribbean countries. Now she is in Jamaica. But before we will, I would like to tell you that the summary of this presentation will be available. Please.
Improving cardiovascular health in primary care.
Para el tratamiento.
The objective of this study was to improve blood pressure control and hypertension registry coverage at 6 demonstration sites in St. Lucia. From January 2020 to December 2021, St. Lucia's Ministry of Health, with the support of the Pan American Health Organization, implemented the HEARTS technical package in 6 primary healthcare facilities with 6 monthly monitoring for blood pressure control and hypertension registry coverage. The modules included healthy lifestyle counseling, evidence-based treatment protocols, access to essential medicines and technology, risk-based cardiovascular management, team-based care, and system for monitoring. Figure 1 shows that the levels of blood pressure control at 6, 12, 18, and 24 months after the intervention were 37.1%, 28.9%, 33.9%, and 36.5% respectively. Hypertension registry coverage increased by 70.8% for patients accessing services. Implementing the Monitoring for Action initiative 12 to 15 months after the start of the intervention resulted in policy and operational changes, improved documentation, and provided accurate and reliable data. The HEARTS initiative unearthed basic infrastructural challenges in blood pressure control. The essential elements for success were 1. Buy-in at all levels of the health sectors. 2. Addressing policy and operational changes. 3. Accurate documentations and required analysis. 4. Standardization of equipment and procedures. And 5. Regular monitoring and evaluation. Capacity building underpin all changes.
Bien, muchísimas gracias, Patrice.
Thank you very much, Patrice, Laura, and which was
experiencia
your
trabajando con HEARTS en el Caribe.
Working with HEARTS in Caribbean.
¿Cuáles son los elementos más importantes para conseguir que un país quiera implementar HEARTS, el paquete de HEARTS en las Américas? Adelante,
Patrice.
Hello, thank you. It's pleasant. Good afternoon to all, and thank you, Pedro. First of all, I wish to express our thanks to the organizers for the invitation to be part of this program. Can you kindly repeat the question? The interpretation was simultaneous to the Spanish.
Sí, cómo no, Patrice. Estoy diciendo, ¿cuáles son
los... Of course. So I was asking you, what are the elements, the key elements in your experience as an assistant in Caribbean, in your position in Caribbean? What are the elements that are so important to make a country decide and go and participate in a program such as HEARTS in America?
Thank you, Pedro. And so if I can begin by providing a bit of a background to the implementation of the program, because initially we thought that this might have been a mitigating factor, but based on your question and our evaluation, we recognize that it was a great lesson that was learned for us in the implementation of HEARTS. And so we prepared for the implementation of HEARTS in 2019, and we did all our training, and we were set to implement in January 2020. And the COVID pandemic hit us in March 2021. And that resulted in two main key results. First of all, we had a decrease in the utilization of services, of the health services, and this directly impacted the hypertension program. And also we had a negative impact in the implementation of the interventions of the HEARTS program. And so what we recognize is that as a Caribbean, we are very vulnerable to disasters and emergencies. And so implementing HEARTS, when we were all planned and ready to set with the implementation and the COVID pandemic, so it taught us how we had to take a look at what we already had identified and conduct an evaluation, and then implement and sort of change the strategies that we were going to implement. And I think this is one of the key elements for success with any program in the Caribbean, because we are indeed prone to emergencies and disasters, and we have to be flexible enough to be able to change our strategies. And so in the first year of implementation of HEARTS, we were directly impacted by the COVID pandemic, and we weren't able to intervene as appropriately as we thought. But by the second year, we met as a group and we changed our strategies. We did a couple of interventions, and we were now able to implement HEARTS and implement HEARTS successfully. So I think that's one of the key things. The other thing is the buy-in, and we got a lot of buy-in from the government, from political aspect, from the different sectors. And in some countries, we had the involvement of civil society and NGOs, particularly in the area of the healthy lifestyle module. So this was another key to the success of the program and implementation in the Caribbean. The third would be the information systems. We had greater success with St. Lucia as it pertains to be able to monitor and evaluate the implementation of the program, because St. Lucia had an electronic health information system in place that perhaps the other countries may have been somewhat limited. So we were able to get the data immediately when we were implementing our interventions. We were able to do monthly analysis and then use this data for action. So another key recommendation to the Caribbean countries is perhaps the need to upscale the health information system to support the implementation of HEARTS.
Muchas gracias, Patrice. Yo creo que es muy
Thank you. This is interesting what you have said, very valuable. We have countries from the Caribbean implementing HEARTS, and it would be excellent, to have, the Caribbean region using the same focus, the same system, the same way, to handle, these things. Well, I was just thinking that when we look at the percentage of control of those with hypertension in the region, Caribbean is one of the regions with the biggest challenge, really. So I believe that one thing that would help is really to have a single focus, single point of focus, single action, single methodology, single system. And this is a challenge, really, to have this done, to have, this is an initiative, right? So this is growing, right? And there are countries that I wanted to present now, which is Trinidad Tobago. Well, Trinidad Tobago is a country that uses HEARTS. uses HEART and they're implementing HEART. And one of these countries is indeed Trinidad Tobago. And we can all learn, we can all learn from Trinidad Tobago. So now I invite, first we will show the article actually, and then we are going to invite our colleague to speak. First, the video.
Improving cardiovascular health with the patient-centered integrated primary care heart module in Trinidad and Tobago. This article describes the introduction of the Pan American Health Organization's Heart in the Americas program in Trinidad and Tobago and the successful experiences and challenges encountered in introducing and scaling up as a strategy for strengthening the health system's response to cardiovascular diseases. Evidence about implementation of the HEART program in the World Health Organization's region of the Americas was carried out to identify the progress made, barriers, success factors, and lessons learned. In 2019, the Ministry of Health commenced the implementation of the HEART program in 4.9% of the 102 primary healthcare centers, and by the end of 2021, it had been scaled up to 46 centers, or 45%. The HEART program ensures that patients' cardiovascular health is managed in a comprehensive way through providing counseling about health lifestyle, using evidence-based treatment protocols, ensuring access to essential medicines and technologies, using a monitoring and evaluation system, and a team-based approach to care delivery. The barriers encountered during implementation include the fragmentation of the existing healthcare system, the paternalistic role assumed by healthcare professionals, the resistance of some healthcare workers to change, and a lack of team-based approach to providing care. Successful program implementation was enabled through ensuring high-level political commitment, establishing the National Heart Oversight Committee, ensuring a stakeholder involvement throughout all phases, and implementing a standardized approach to care. When implemented in the context of existing primary healthcare settings, the HEART program provides an exceptionally well-integrated and comprehensive model of care that embodies the principle of universal health care while ensuring the health of both populations and individuals.
Bien, muchísimas gracias por este resumen. Le pido
Well, this was a video to sum up, right? And I would like to, I really appreciate those who had spoken, Patrice and Lawrence and Dr. Thomas from Canada. I mean, this was great, and I will have you guys speak with us here. I will begin with Tara. I mean, she was one of our members there in Trinidad Tobago, had a very important role with us there in HEART in Trinidad Tobago. Well, Tara, listen, in this article in the Pan American magazine, I mean, this was published, and in your opinion, the question that I asked Patrice, the same question, but different context, right? So basically, this is a difference, right? But in your case, in your country, are you in agreement with what Patricia mentioned, what happened in her country compared to your country? So what can HEART really offer any country really in the Caribbean region? I mean, what can HEART really offer?
Thank you, Pedro, and good afternoon, everyone. It's really a pleasure to be with you this afternoon to share some of the work that has been done in Trinidad and Tobago as it relates to the implementation of the HEART initiative. So just as Patrice mentioned, the HEART initiative is really that approach that is stepwise, that is practical, that is able to show results over a period of time. So to make it successful, the high political commitment is extremely important. So for countries that have not yet signed on to implementing the HEART initiative, their first steps or the first suggestion that we would make is for them to present all this evidence that was presented here this afternoon in the webinar, showing how effective the program has been, showing how we're able to reorganize and strengthen the provision of care at the primary healthcare level, is one of the greatest assets to getting the political commitment that is necessary to move the program forward. So similar to Patrice and what happened in St. Lucia, for Trinidad and Tobago, we started the implementation of HARTS before the pandemic. So we were able to start seeing the dissemination, and we had the clinical pathway. We started as well with the healthy lifestyle counseling through the chronic disease self-management program. We also started in terms of the M&E and ensuring that we had the registries in place to start establishing what the baseline coverage and control were, so that as we were implementing, we are able then to do the monitoring to see the impact that HARTS have had on the control and coverage of hypertension in Trinidad and Tobago. So yes, the program was disrupted to some bit by the COVID-19 pandemic, similar to what has happened in all the other countries where our primary care centers, while in Trinidad and Tobago, there was a parallel health system, meaning that they had specific centers organized for treatment of persons with COVID-19, which was to allow for the established primary care system to continue operating. However, because of redirecting of the same healthcare staff to staff these facilities, as well as just the fear of the population in terms of going to facilities, we saw a significant reduction in the number of persons turning up at these facilities to seek care. But what that has done was create an opportunity for us to find new ways, new and innovative ways to really reach the population. So that resulted in the team transitioning to the telemedicine, reaching out to our patient, and that's the beauty of having your registry. And when we're talking of registry, it doesn't necessarily mean a nice fancy electronic system. Some countries, yes, may have that, but for the countries that don't, we want them to understand that we're starting with what you have at the moment. And that's the beauty of HARTS. We start with where you are, because HARTS is a quality improvement. It's helping you to strengthen and mainstream what you already had. So for Trinidad, majority of our health center had only paper-based registry. So we were able then to use those paper-based, using the M&E component of our package to identify those core indicators that were necessary, and we standardize the collection of those indicators at each of our implementing centers. So when we started the implementation, we started with 5 facilities, 1 in each of the RHAs. So in Trinidad and Tobago, there are 5 regional health authorities. So we started with 1 in each. By 2020, we had scaled up to 35 facilities, and by the end of 2021 to the beginning of 2022, we were able to scale up nationally. So all 102 primary care facilities in Trinidad and Tobago are currently implementing the HARTS initiative. So in summary, is basically to say that we have seen the benefit of HARTS. It allows countries to start where they are at the moment, and to take a stepwise approach to improving, targeting and strengthening what exists at your primary care facilities. So I would encourage all countries in the region of the Americas to come on board and join this initiative to implement the HARTS initiative, to implement this program throughout their countries. Back to you, Pedro.
Bueno, excelente. ¿Qué tal?
Well, excellent. Well, excellent. Let's applaud, huh? North Campbell Inc. Canada, best program in the world, huh? Patrice. Oh, I mean, this was a great program in St. Lucia, you know, the countries in the Caribbean, and Trinidad and Tobago. So really, congratulations. And I mean, I really want to see your article. I really want to see the article from St. Lucia, from Trinidad and Tobago. I mean, everyone really. I mean, in the Caribbean, we got St. Lucia, Barbados, Trinidad and Tobago, Dominica, Belize, Guyana, Suriname, Bahamas, and Grenada. Well, I mean, we are going through with this. We're moving forward. We're getting better, and the Caribbean is really a point, right? A point in the world for hypertension. I mean, such an important point. I mean, such an important issue, really. And we need to have a protocol. We need to have a common protocol. We need to have a protocol that is a standard protocol that can really guarantee, you know, this implementation. You know, so I want to close this with a surprise. Sarah, how many deaths can we save in Trinidad and Tobago? How many deaths can we save or have we saved? I mean, if we implement HART in Trinidad and Tobago, if you hadn't done it, and now that you have done it, have you done the mathematics? Have you checked these numbers? I mean, let's see how many deaths is possible. I don't know if Tara is there, if she can guess, you know, and Patrice, let's see if you can guess in your minds, you know, and let's see from Ramon, let's see, I mean, we have the tool, let's go to Trinidad and Tobago, huh? So let's select Trinidad and Tobago. So Trinidad and Tobago, right, let's see, let's select it here. So 1.5 million inhabitants, the control is low, 21%. Well, this was the last analysis, but Tara was telling us, we're going to improve this. We're going to improve this, right? I mean, we heard from her, right? So yeah, we hope so. We hope so. We definitely hope so. And I'm going to have it here. Let's see. Well, on the other hand, we need to know that in Trinidad and Tobago, when we see the level of treatment, the number here, so we see treatment, I mean, we see that the actual rate of diagnosis, which is 60-something%, this is 2019, the latest number that we have. Looking at those who know their condition, right, we have the percentage here on the screen, and the control, which is 44.8%. You can see here on the screen. This shows that this is 20.9%, right? So 20.9, huh? So now let's suppose that we want to elevate the rate of diagnostics to 80%. This is an aspiration, right? This is wishful thinking. Well, Ramon, you're saying this, but this is what Canada has, right? It's realistic, right? Because Canada has 80%. So they have it. So it's not really a dream, right? It's possible. Well, this is only for the sake of looking at this diagnosis, right? I mean, 80% is a big deal, sure. But if we were able then to get to 80%, we could elevate the control from 20.9% to 27.7%, and we would save 300 plus and 138 for stroke and 200 something for hypertension. So these are just ideas. This is just an idea. I mean, we're considering here, considering population of 1.5 million inhabitants. So we're looking at the numbers. We're hoping to see it this way. We're hoping to see this in 5 years. And you can change the data. So you can change it. You can have more years. You can have fewer years. You can look at this the way you guys want. So I'm gonna consider here 5 years, right? So for example, so I mean, we wanna look at this. We wanna change the percentage. We want to keep the rate at 80%, as expected. If we get to 60%, really, if we get to 60%, we can actually see it at 37.3%. So the savings here, we could really avoid, really, we could reach something like 1,080 something cases. So that's the number. So anyway, well, this is great. This is great, Ramon. This is great. This is great. I mean, Ramon, I like it, but this is an instrument, a tool. I mean, you guys should do it. You know, I mean, have the link there. You know, you can use it. I mean, you can check it out. You know, I was looking at Buenos Aires province. The thing is, it doesn't have to be this way. You can check any country, any region. And if we look at this, we see that we are improving in diagnostic. We're improving in control. We're improving in this. And we see that this program is worth it. It's an intelligent investment. Thank you, Ramon. Thank you. Thank you for really showing us this. And I will ask the team to go to the last segment. Thank you, everyone. North Campbell, Patrice, and Taran. Thank you so much for joining us here in this webinar. I mean, it was great to hear from Canada, St. Lucia, and Trinidad and Tobago. Well, thank you now. And now, let's go to the last segment.
Let's make a start. It's good for the heart. Somebody say it is for health, it is for health. Give me the E for energy, E for energy. A is for all our way, A is for all our way. Give me the R for ready, R for ready. The G, the S, take the test. The T, the S, team no stress. H-E-A-R-T.
Bueno, qué bueno, qué bueno, qué bueno, qué bueno, qué bueno.
Well, fantastic, fantastic. I mean, this was a quick pause, right? We should always move our bodies, you know, exercise a little, right? It's important to get ourselves moving, yeah? So this is a video that we got. I mean, this is great, huh? This is great. They made this video, and it's really great, huh? St. Lucia, it's very excited with this. Well, now the last segment to finish our webinar. We know, very intense, huh? We're celebrating this webinar right now. I mean, this is the Stroke Day, right? The World Stroke Day. So, just to introduce this, I was just reading this article, and this article was shared by one of our consultants, and the topic is that in Latin America, well, in the Americas, really, the number that we can actually look at hypertension, the number of people that is related to other diseases, right? And this is an article, an interesting article, as you can see here on the chat. It says the association between population hypertension control and ischemic heart disease and stroke mortality in 36 countries of the Americas. So this really, we can see the numbers, 53% increase, 37% can be attributed to the IMC. So these two things get us to like almost 90%, right? For those risk factors. Huh? So it's very good that we look at hypertension as a key element for primary, secondary, for those cardiovascular events. So I will bring here a leader, a real leader for this, I had the opportunity to meet in Brazil, right? And we were able to see what was going on in Brazil. And we're going to have a webinar from Brazil and in Brazil, right? You are from Brazil right now. You can definitely talk to us. Huh? We really want to do it because there's a massive team there in Brazil. She is Sheila Martins. She is really great. And she will offer us final words here. Let's welcome Sheila Martins. Let's hear from her. Let's hear from her. Let's go, Sheila. Thank you, Sheila. Oh, hello, Pedro. Fantastic. I hear you. I see you. No, bring us
Hello,
your
Pedro.
energy, right? Your
It's a
Brazilian
pleasure
energy.
being
Oh, it's
here
great to be
to
here with
speak about this
you
program that
to
is so
speak about this
important. I'm in
program.
Singapore
I
right
am now
now
in
in the
Singapore for the
World
stroke, at the International
Summit
Stroke
of
Conference.
Stroke
We spoke about
and
hearts.
speaking
We
about the
support
heart and how
hearts
we
because
support
really
heart
we believe
because we
that this
believe that this program is
program is
key for the
key to
impact on
reducing
stroke,
stroke
not only in
rates
Brazil but
in
abroad.
Brazil and in the whole world.
So
So we
supporting
support
the
implementing
implementation
hearts
because
because
hypertension
it
is
is right. Hypertension
the
is
main
the
cause,
basic
and the
cause
reduction
for
of
stroke. So
hypertension
if we
together
reduce
with other risk
hypertension, we
factors
reduce
can be a
stroke.
huge
So
impact in
this is
reduction of the
really
disease.
massive. So
And
we
this
really
program,
expect
we aim that this program is
that
during time
you
to
know
reduce
that we
up to
get to have
50% the
a
incidence and
lower
cases.
incidence of this.
I'm going to
So
speak
basically, I
firstly
am going to
what
share
we're
with
doing in
you
Brazil.
what
We
we're
are
doing
supporting
in Brazil,
internationally the
and I want to
implementation of
share with
PAC.
you what we're
That's why
doing.
we
So this is
started
how
implementing
we
in my
started
city
doing things, right?
with the
So this is
cooperation of
a
the
cooperation, right, in Porto with
health
the City
secretary,
Hall,
with
Porto
together with
Alegre
PAHO,
in Brazil,
and with the Ministry
and
of Health
basically we got engaged
related
with
to
hearts,
this,
and
and
then we
they started
started
helping in
doing
the
this
heart
together.
initiative.
So
The
looking at
care
stroke
for
in
a stroke
Brazil, we
in
have
Brazil
been
has improved
improving really. We have really been
severely
developing,
with acute stroke
strategies
care, but it was
for
not enough to
preventing
reduce
acute
the
stroke.
amount of cases.
So,
We
but this
had
still we
400,000
have about
cases
400
each year.
cases
So
that
we have a
occur
huge
each year in
experience
Brazil.
in this
So I am
center,
very connected to many
stroke
centers
in
in Brazil,
Brazil,
but
but
we see
we
that easily
noticed that
this is
this
not
is
enough,
not enough.
not
That's
yet
why
enough.
I
That's
related to
why
this.
I'm very engaged in
This
this
study was
program.
very
This
important.
study
It
is
was
very
on a
important. This really
population
looks
following
at
this
the
stroke,
number from the World Health
assessing the
Organization,
incidence
looking at the
and
incidence, looking at the
functional in all
evolution,
cases of
looking
stroke
at
in
all
4
cases of
cities
stroke
of
in 4
Brazil,
cities
distributed
in
in 4
Brazil in
different regions.
4 different regions.
What we
And
saw
this
is
study managed to
mortality in
see that
Joinville,
mortality, as you can see here, stroke
when the
mortality
first
in Joinville,
stroke
which is
unit
a
was
city in
created for
Brazil, we see
the
that
main
this beyond what we have
situation
also. But anyway,
related to
looking at
the
the
whole
whole primary
network
care
of
network,
primary
the education
care,
of the people,
the
the
mortality in
mortality
1
in
year
1
was
year was
17%.
17%.
In the other
In other
cities, the
cities,
mortality
mortality
was
was absurd.
huge.
I will
And I'm
show
going to
you.
show the
Look,
worst.
Sobral
Sobral
had
had
49%
49%
mortality
mortality,
rate.
stroke mortality. We cannot accept that within the same
We
country
cannot
we have a
accept
disparity
in the
that
same
did this.
country, right?
Not
We
only
cannot
by the
accept this, not
organization of
only for
acute
acute,
care, because
but
in
we
Sobral they
know that
don't
in
have
Sobral there
any
is not
unit, stroke
one
unit, and they don't have
center
treatment
for
for this
stroke. We know that this is the case,
patients when they get to the
but they would
hospitals, but they were
arrive, with
younger
the more
and more
severe and
acute.
younger.
So
So we
showing
know that the risk
that
factors
these
are
patients
indeed a
are
big deal.
caring
We
for
know
the
this, right? We know this.
the
So basically,
prevention,
we see that we have
we
issues here.
can
We need
act
to work on this. So,
strongly. So the
and then there's
second
another
study
study.
compared in the same city with the same
Basically,
team,
we look at the
the public
thinking for stroke,
hospital, public and private,
and
the same care
we
offered.
see that there's a functional element. So for those
They had
patients that will
more
have more collateral,
problems in
who
their
have more
public
symptoms,
hospital,
I mean,
and not because
basically,
of this treatment, but because they were more severe and more comorbidities, not controlled, and younger, showing that
so
we
this
are
shows that we
failing
are
in the primary
failing in
attention.
primary care,
So
basically.
in
So
2020, we created a Global Stroke Alive initiative that was in Brazil. the World Organization of Stroke, the Secretary of Porto Alegre, implementing a study that is, if it's increased in 120, 130, they need primary attention and the compromising of the new implementation, because we are working in the auxiliary, in the implementation of HEART program, and the city of Porto Alegre, because they were the first to sign with the World Organization, Health Organization. So the doctors, the family doctors, to discuss with SAT, to discuss the protocols through HEART for us with drugs that were for free, for us to identify and treat properly. We had 10 primary care units together with the Secretary of Health of Porto Alegre. We created a protocol, HEART protocol, for our reality that we have in Brazil, and we implemented a protocol for the patients 55 years old up, and for another app for the implementation of a risk meter for them to check their lifestyle, preparation of education course for primary care professionals, including community health workers, and implementation of a tool for decision data collection and artificial intelligence for the nurse to collect the data of this patient, to know information of the risk factors, to measure the heartbeat at the door. The patients up for above 55, they check the cardiovascular risk, and they, when they get to the doctor, they have assessed already. And after implementation, identify better treatments for application for long term polypill and diabetes. We are studying a clinical study to improve their health. This is our first meeting that we had, talking Pajo from Brazil, specialists from the Ministry of Health. They were gathered together in the preparation of this work. This is the software we implemented, and the health units. The questions are ready. It's very easy. It's just clicking. It's 6-7 minutes to fill everything with 2 measurements, pressure measurements, and it makes the calculation automatically for the body measurements, and it was the risk, the stroke. And when the doctor gets them, they have this already. This is the cardio to calculate, and this is the summary of the patient. When they get to the doctor, it's all filled, and the software reminds the patient if they have diabetes, if they have nephropathy, or any other, if they have obesity, if the patient is not hypertension, and they're going to choose a protocol. This is the training program. This is very easy. There's a video on how to measure the heartbeat, and these are the gathering of the 132 care units that we have, the training. And in September, we trained another 133 units, more than 1,000 professionals, more than 400 doctors in different days. We had 4 hours each on the Secretary of Health of our city. And the combination was to begin, every unit needs to measure the pressure, and then they implement the software. We implemented in 2 units so far, and we are adapting the protocol, and the protocol is going to begin now. The coordinator of the primary attention, the first coordinator, Franciele, here are 200 agents, community agents, and this is the Ministry of Health, the unit they chose for the unit in Porto Alegre. We helped with the implementation. This is the heart that we're assessing, and this software created dashboards already the age, risk factors, the obesity, and risks. We have the percentage of hypertension and how many patients say they are not hypertensive, but they are. In Global Stroke Alliances 2 months ago, we represented the PAHO with a huge implementation stimulus. And this is Professor Patricia, who is doing an incredible work in Brazil. This is the PAHO team and have been a very an amazing partner. We have the city. I'm Singaporean, the Stroke World Congress, and my team is checking the risk factors, the implementation of the program. In this Global Stroke Alliance, we had more than 1,200 participants and the different specialists and different lines of attention, talking to the managers, health managers. We had the Latin America Stroke Ministerial meeting and 7 Ministry of Health showing their experiences and sharing or hearing what can we implement after this meeting. And we had several people there trying to implement HEART in Uruguay. And then we want to implement this initiative. This is Professor Taskin Khan talking about the HEART initiative. This is what I had to share with you. Thank you very much.
Wow, fantastic, fantastic, fantastic. Really, really, really what you guys are doing and how this integrated all, right? All care, primary, secondary, I mean, really improves acute cases, all cases, all patients. So, I mean, the amount of things that you do, this is really amazing. Sheila, listen, we've been here for 2 years, huh? For 2 hours, huh? And we've got here the full audience. We've got 454 people here. Everyone listening to you here, it's a privilege here to have you. It's really a privilege to have you here. So, I mean, it's great to have her in this webinar. And last time we had, another great presence. So this is what it means, really, that for cardiologists, neurologists, family doctors, specialists, I mean, for everyone that is here, get together, really, and get our strength together to be a reference for improvement. I mean, I will really ask all panelists, let's say goodbye to everyone. I mean, really appreciate everyone for being here. So much good information. Of course, we had 1 or 2 glitches. This happens, right? I hope that you forgive us for this. We appreciate you a lot, and it is worth using HEART. It is worth participating in HEART webinars, and it is worth to share so much good information with everyone and improve cardiovascular care. So let's have your cameras on, panelists, so we can say goodbye. And let's have our team also say goodbye. Let's see your faces there from the HEART team. You see? I see North Campbell, I see Sheila. I mean, this gives me peace of heart, peace of mind, really, because it's really something good. We see Ariana, thank you. Thank you for participating in this webinar. I mean, it's great to have had you here. We see Cynthia, Patrice. Oh, thank you, Patrice. Angelo, Eduardo, Gloria, Ramon. So many wonderful people from so many different countries, and this is our adventure called HEART. One more webinar. I mean, we really thank everyone. Everybody's here, right? Everyone is here, and we see it all. See you next time. Thank you. We will keep on celebrating this special moment together with the Pan American Health magazine. I mean, I really want to tell you again, I mean, Uruguay, huh? Uruguay's great. Uruguay's doing it. Uruguay's doing it. They're in. Yes, they're in. Yeah, if you say so, then they're in. I mean, I really want to, I'm so glad, I'm so thankful. Thank you, everyone. Thank you. I really wish you a good afternoon, and let's celebrate this day, and see you next time. Let's improve cardiovascular care. Thank you, everyone. Thank you for the team. Thank you for everyone who was here. Thank you, translators. Thank you, the team. Thank you, every participant. Let's listen to some music, and then we end our webinar here today. Thank you.
Merci.